I'm really pleased to be involved once again in the ISMA conference, which I've always enjoyed very much, and I believe it's an extremely important opportunity to improve understanding of science and the management of people with metabolic diseases. So thank you once again for inviting me. And also, thanks for providing this very interesting title that I would like to, of course, address in the next minutes, which deals with a very new concept, which is the remission of type 2 diabetes. We will review what we mean by remission of type 2 diabetes today, and we will specifically, I think, consider in a timely fashion, the role of new therapies that are just there at the horizon for the diabetologist in order to treat our patients with more ambitious goals, including, again, potentially also the remission of the disease. I would like to start by recalling that the concept of diabetes remission for type 2 diabetes, of course, has been very much associated with the results of bariatric surgery. What you see here is the design of one of the most important studies with different surgical procedures that were carried out in people with type 2 diabetes, looking at metabolic endpoints, which we'll see in a moment, and not just the reduction of body weight. So this is a study which was coordinated by Professor Mingrone, Gertrude Mingrone in Italy. And as you see here, it's not a very large study, but has the advantage of being one of the first studies addressing the possibility that bariatric surgery could really very much improve the outcomes in people with type 2 diabetes, looking at glucose control. So in this particular study, patients were randomized to receive the standard medical therapy, or they were treated with two surgical procedures to lose body weight. One is biliopancreatic diversion, which is a malabsorptive intervention, as we may recall from previous use of this technique, mostly in the past. And the other group was randomized to Roux-en-Y gastric bypass, which is still very much used in many countries as a procedure for bariatric surgery. Patients were very much compliant, so the numbers are not very large, as I said, but in the vast majority of the cases, patients completed the study. So it was possible to look at the changes in glycated hemoglobin over 2 years of follow-up. And what is apparent from this study is that medical therapy is able to reduce HbA1c from a mean level of baseline level of 8.5% to a level between 7 and 8%, as often occurs also in our current practice. But that you can see how the two surgical procedures, including gastric bypass and the biliopancreatic diversion, were much more efficient as compared to medical therapy in this particular study. So the mean levels of HbA1c were far below 7%, and for the biliopancreatic diversion, they were also very much in the normal range between 5 and 6%. So this is clear that the surgical procedure, bariatric surgery, is able to induce a condition of normal glycemia in the absence of pharmacological therapy for type 2 diabetes, which is indeed what we would consider a sort of remission of the disease. Going on with the time and the literature, we come up with this other very important study, which was published only a few years ago in Cell Metabolism, was coordinated by Roy Taylor. This is even a more interesting study because it does not only provide the evidence for remission of the disease, but also some hints about what could be the mechanism behind this process of the remission. So in this study, patients were again characterized by having type 2 diabetes in excess of 6.5% in terms of their HbA1c level, and they were randomized to some conventional treatment, which we will call control, or to intervention, which consisted of a very low-calorie diet. And if we focus on the intervention group, we can appreciate also how there were some patients that were called responders and patients that were called non-responders that behaved quite differently in terms of the weight change and especially the HbA1c modifications over time. So if you focus on the responders, which are the continuous lines as compared to the non-responders, which are the dotted lines, you can see how the two groups were characterized by similar reduction in body weight, but in terms of glucose levels, the responders were characterized by a much more prominent decrease in both fasting plasma glucose and also in HbA1c as compared to the non-responders, which were more similar to the controls who did not receive any, any dietary intervention. So it is clear that when you put patients with type 2 diabetes on a stringent diet, there are some patients who will really normalize glycemia because the mean fasting glucose in these responders were around 100 and the mean HbA1c were equal or even below 6%. So this is a very interesting subgroup of patients. So in this study, these patients were further analyzed in terms of liver fat, in terms of pancreas or pancreatic fat, and also in terms of changes in triglycerides or in triglyceride-rich lipoproteins. And again, there were some interesting findings here because what you see is that the liver fat was decreased in both groups, the responders and the non-responders, as was the pancreatic fat, which was decreased in both the responders and the non-responders. There were not many changes, much differences in terms of the triglycerides, especially the circulating triglycerides, even though for the very low density lipoproteins, the responders were characterized by slightly lower levels. But in essence, what we can appreciate from these findings is that there is no much of a difference in terms of the changes in fat content of the liver or of the pancreas. What is really different in these two groups, the responders and the non-responders, those who normalize glucose levels and those who do not normalize glucose levels, is something that has to do with beta cell function. So beta cell function was indeed preserved in the responders, whereas it was more deteriorated in the non-responders as it was in the control patients. And also in terms of maximal insulin secretion, you can see here that this was there was a trend to better maximal insulin secretion in the responders as compared to the non-responders and also to the control patients. So the conclusions of this interesting study is that in order to go from type 2 diabetes to remission of this disease, you need to reduce liver fat, you need to reduce also the pancreas fat, you need to probably affect the lipoprotein metabolism in a favorable manner, but most of all, you need to improve your beta cell function, which is the key difference in terms of what is needed to restore normal glucose levels. So it looks like reducing organ fat at the liver level or at the pancreas level is a necessary but not sufficient condition in order to induce the remission. The remission is really very much around the possibility for the beta cell function to be restored, to be recovered, to improve in response to the very low calorie diet. And as we consider the transition from remission to type 2 diabetes again, the relapse, again, we should think that this is probably very much associated or related to deterioration of beta cell function. So this is the most, I would say, updated hypothesis as far as what we can consider today for remission of the disease. And in regard to the appreciation of the scientific community in relation to what these studies have suggested or demonstrated, there was a recent panel of experts that were trying to redefine what we should consider as remission of the disease. So first of all, this panel, and this is a document that was published in Diabetes Care last year, they were trying to make a difference between different wordings. So remission is not resolution, is not reversal, is not cure of the disease. And we can understand why we call remission something that is different than resolution or cure, because resolution or cure is a kind of more long-term condition in which the disease is no longer present throughout life. Reversal is different because it means that you can revert to a condition of normal glucose levels, but this may be associated and still needing the use of pharmacotherapy. So remission is probably the most appropriate term to be used, and we know that in order to consider what can induce remission of type 2 diabetes, definitely bariatric surgery, as we have seen, is one modality, one tool to achieve that goal, as also the marked dietary intervention, the very low calorie diet, or even the very low ketogenic calorie diet. We also have to remember that some earlier studies have shown that if you treat at the diagnosis of type 2 diabetes, these individuals with intensive insulin therapy, potentially even with a pump, you can also there potentially induce some kind of remission in terms of these patients not requiring other drugs after withdrawal of that insulin therapy. Also, the combination of newer agents that do not cause hypoglycemia, including GLP-1 receptor agonists and SGLT2 inhibitors, sometimes may be associated with a similar phenomenon of remission, which persists even after withdrawal of these agents. And we will discuss more in detail the possibility that tirzepatide, a novel dual GIP-GLP-1 agonist, may be inducing remission of the disease. We will definitely see how this agent is able to induce reversal of type 2 diabetes or regression to normal glucose levels. We don't know yet whether it is able to also induce remission. So this panel was quite keen, I would say, in defining what we should consider today as remission of type 2 diabetes. They think that it is appropriate to consider remission a return of HbA1c levels to less than 6.5%, or fasting plasma glucose lower than 126 milligrams per deciliter, or a CGM-derived estimated HbA1c lower than 6.5%. So a return to these levels of glucose or HbA1c that occurs spontaneously or following an intervention with the drug or with diet, and that persists for at least 3 months in the absence of usual glucose-lowering pharmacotherapy. So to consider remission, we have to observe the patient without medications for at least 3 months with an HbA1c lower than 6.5% or fasting glucose lower than 126. You can see here how for the different intervention, either pharmacotherapy or surgery or lifestyle, we have different intervals that we have to follow before testing of HbA1c in order to reliably evaluate the response. So 3 months after cessation of pharmacotherapy, or 3 months after the procedure, and 6 months after the beginning of lifestyle intervention, and 3 months after cessation of any pharmacotherapy when we consider lifestyle. In order to subsequent measurements of HbA1c to document continuation of remission, this should occur no more often than every 3 months, no less frequently than yearly. So in other words, not too frequently, not too rarely. So at least once in a year. And what we have to also consider when we look at this scenario is that weight gain, stress from any forms of illness, continuing decline of beta cell function can all lead to a recurrence of type 2 diabetes. So one should really watch out very closely for the possibility for glucose levels to return to the diabetic range, and also the complications which may develop even in the absence of hyperglycemia because of the negative legacy effects. So the burden of the disease that occurred before the intervention, which, as we know, can continue to exert its effects over time. So we have, especially looking at what happened in the Taylor's study, we have evidence that since diagnosis of the disease, we can probably induce some changes that will result in remission of the disease when we act early, meaning before 6 years from diagnosis, and when we lose at least 10 to 15% of body weight, because under these conditions, there will be a sufficient reduction of liver and pancreas fat. And in some individuals, as we have seen, there will be also an increase in insulin sensitivity and especially in beta cell function, which is key for type 2 diabetes remission. If we consider individuals with longer duration of the disease, then it is possible that we may need, in that case, a greater level of weight loss ranging from 20 to 25%. But this has to be proven because we don't have evidence for this approach to be effective also in people with advanced disease. And we have to also consider that in terms of predictors of type 2 diabetes remission, the age of the individual, the baseline HbA1c, the number of diabetes medications, the insulin use, the duration of the disease, as we just discussed, are predictors. In other words, the younger the patient, the lower the baseline HbA1c, the lower the number of diabetes medications, the absence of insulin use, and the shorter duration of type 2 diabetes are predictors of a higher probability to observe remission of type 2 diabetes. It is also important to understand that as you lose weight and you want to achieve diabetes remission, there is a threshold of magnitude of weight loss that needs to be achieved for that process to take place. And this was very clearly shown in this meta-analysis of bariatric surgical weight loss for initial diabetes remission that was carried out in a very recent article in Diabetes Care. You can see how in this meta-analysis, almost 6,000 patients were analyzed. These patients had a mean age of 50 years and a mean BMI of 43. The majority had Roux-en-Y gastric bypass, and about 2/3 of the population experienced initial type 2 diabetes remission, with a mean time to remission of about 1 year. Type 2 diabetes remission was defined as the first date for which a patient met both of the following criteria: no diabetes medications failed, and either HbA1c lower than 6.5% or fasting glucose lower than 126, as we just defined the remission based on the panel's consensus. So this is an interesting meta-analysis which tells us that the significant increase in the likelihood to see diabetes remission occurs when the loss of body weight is in excess of 20%. So once you achieve a 20% weight loss or greater than that, then you are better off to experience diabetes remission with a hazard ratio or odds ratio of about 3. So clearly, another interesting observation from this analysis is that if you lose 20% or 25 or 30 or in excess of 30, the benefit is not that different. So it looks like it is enough to lose at least 20% of initial body weight to see diabetes remission. And it's not required to lose a larger extent of body weight. This is also what a real-world study recently showed. This is a very nice paper published in PLOS Medicine based on a survey in Scotland in 2019, in which you can clearly see that as you look at age, diagnosis, HbA1c, glucose-lowering therapy, weight change, bariatric surgery, there are some factors that are associated with a very high odds ratio of achieving diabetes remission. And these include the absence of pharmacotherapy, the glucose-lowering medications. It includes a weight loss of at least 10 kilos, I would say. And it includes, of course, the previous use of bariatric surgery, which is clearly very effective in inducing remission of diabetes. Now, I would like to finish with some other data that are not really, demonstration of diabetes remission, but it's really a scenario that is very close to what we have been discussing so far, because we know that incretins hormones are very effective in inducing insulin secretion. And we have appreciated how not only GLP-1, but also GIP is a very important factor or actor in this process. So it has been estimated that if glucose is responsible for about 33% of the insulin release, we have to acknowledge that GLP-1 is responsible for about 22%, and that GIP, the glucose-dependent insulinotropic polypeptide, is even more important, being responsible for about 44%. So it is, I think, conceptually, logical that if we combine the actions of GIP and GLP-1, we could have a very powerful tool to stimulate insulin release, also in type 2 diabetes. Another concept that we have to remember is that GLP-1 action on the human hypothalamus is possible because we have receptors for GLP-1 in the human hypothalamus, and these mediate satiety and weight loss. But there are also receptors for GIP in the human hypothalamus, sometimes in cells that express both receptors, or in cells that express exclusively GIP receptors. And it has been shown that if you activate these receptors, you have important effects on food intake. So the activation of the GLP-1 receptor is able to reduce food intake. And if you use an activator of GIP receptors, you can also have some degree of reduction of food intake. But you can also reduce the nausea and vomiting that the activation of the GLP-1 receptor is able to mediate by activating the GIP receptor as well. So this is the basis for developing dual agonists that will activate the GIP receptor and the GLP-1 receptor, and will have, as we will see, prominent effects on both beta cell function as well as on satiety and weight loss. The most, I would say, promising, but promising is probably an underestimation or appreciation of what we know about tirzepatide, is this dual GIP-GLP-1 receptor agonist that has been developed over the last few years. It's a multifunctional peptide based on the native GIP peptide sequence, which has been modified to bind not only the GIP receptor, but also the GLP-1 receptor. It has actually a higher potency, closer to native GIP than to native GLP-1 in terms of receptor activation. And it has been coupled with a C20 fatty acid moiety, which is what you see here, in order to bind albumin and to prolong its half-life, which is indeed of about 5 days. So this enables once weekly dosing, can be administered only once a week. Tirzepatide, which is developed by Eli Lilly, is a multifunctional ligand that will activate these two receptors, and therefore it is expected to work in knockout mice which lack either receptors. So you can see here in this very interesting experiment how mice lacking the GIP receptor respond to tirzepatide, which is the lines in purple or in violet here. You see that the glucose-lowering effect of tirzepatide is fully preserved also in mice lacking the GIP receptor, as it is also in mice lacking the GLP-1 receptor. So if you knock out either receptor, tirzepatide will still work. Whereas GIP, which is in beige, will not reduce glucose after an intraperitoneal glucose tolerance test in the mice lacking the GIP receptor. And on the other hand, semaglutide, which is a GLP-1 receptor agonist, will not work to lower glucose in the mice lacking the GLP-1 receptor. So this is a very interesting experiment that clearly shows how tirzepatide can work in the absence of either the GIP receptor or the GLP-1 receptor. And this is different than semaglutide or GIP, which will not work when the respective receptor is being knocked out. In summary, tirzepatide will combine the actions of GLP-1 receptor activation, which we know very well, and include induction of satiety and stimulation of insulin secretion, reduction of glucagon, slowing of the gastric emptying. So it will combine these actions with specific actions that relate to the activation of the GIP receptor, which include, again, reduction of food intake, reduction of nausea, stimulation of insulin secretion, and interestingly, some improvement of insulin sensitivity, which is very much related to the fact that GIP is able to affect the adipose tissue to promote lipid buffering capacity of the adipose tissue, which, as we know, will reduce inflammation and improve the ectopic lipid accumulation, especially reducing liver accumulation, so fat accumulation in the liver and in the pancreas, which, as we have already discussed, are very important to improve the metabolic effects of any intervention. So it is believed that, as we will see in a moment, tirzepatide is able to not only increase insulin secretion, but also to improve insulin action due to these effects on body weight loss and reduction of ectopic fat accumulation. It is exactly what has been very recently shown at the last ESD meeting. This is still unpublished data. When people with type 2 diabetes were subjected, were analyzed with a hyperglycemic clamp, it was clear that if they were treated with tirzepatide, they experienced a better increase in the first phase of insulin secretion, not only as compared to placebo, but also as compared to people treated with semaglutide. So the tirzepatide is a more potent stimulator of insulin secretion as compared to semaglutide. When the euglycemic hyperinsulinemic clamp was performed in these individuals, it was clear that tirzepatide was able to improve the glucose infusion rate, not only versus placebo, but again versus semaglutide at the dose of 1 milligrams, which is what we currently use to treat type 2 diabetes. So again, showing that it is a more potent agent to improve insulin sensitivity as compared to GLP-1 receptor agonists. There's also another interesting concept, which is related to the glucagon levels. You can see here how during a mixed meal tolerance test, the levels of glucagon were more reduced with tirzepatide as compared, again, not only to placebo, but to semaglutide, especially if you look here, what happened after week 28, it is clear that there is a more important effect on reducing glucagon, which is something that is one of the mechanisms of action, including the others that we have discussed of this new GLP-1 GIP dual agonist. And another important piece of observation was also presented at the last ESD meeting and shows that liver fat content is reduced to a larger extent with tirzepatide as compared to insulin degludec. This is the proportion of patients with liver fat content less than 10% after 1 year of treatment. You see that this proportion of patients is higher with tirzepatide as compared to insulin degludec. So it is a drug that we really are looking forward to use in clinical practice, also because we already have data from the phase 3 program of development, which is called SURPASS. In this particular program, there was a need to increase the dose very slowly because this will minimize the nausea and vomiting that is associated with the use of the drug. So you have 2.5 milligrams increments that are implemented every 4 weeks. So it takes 1 month to go from one dose to the upper dose. So this means that in these trials, there were 3 arms of tirzepatide, 5 milligrams once weekly, 10 milligrams once weekly, and 15 milligrams once weekly. And these were achieved with different time frames. Of course, in order to go up to 15 milligrams, you have to wait for 20 weeks because of this titration protocol to be fulfilled. And we have from this program very interesting data that span the whole natural history and the regimen complexity of the disease, because tirzepatide has been used in people with short duration of the disease versus placebo, people with a background of metformin versus semaglutide, in people with metformin plus minus SGLT2 inhibitors, comparing this drug with insulin degludec, in combination with insulin glargine in SURPASS 5, and also in a trial that has not been disclosed yet versus insulin lispro. And there's an ongoing trial which is called SURPASS CVOT, which will explore the potential benefit of tirzepatide versus dulaglutide on MACEs, so major adverse cardiovascular events. So this is another very important piece of information that we will be able to see in the future. And please note that now we have release of 5 studies, SURPASS 1 through 5, all published in extremely high ranking journals, including Lancet, New England Journal of Medicine, and JAMA. I will show you now a couple of tables that illustrate the potency of tirzepatide in people with type 2 diabetes in regard to HbA1c reduction and also in regard to body weight changes. So you see here again the 5 studies, the number of patients treated, the duration of the trial, and the baseline HbA1c and the comparator, as I already discussed. And you can see here that in all studies, we can see a very large decreases in HbA1c, which range from 1.87 to more than 2.5. So really very strong reduction of HbA1c from baseline, which is larger definitely than any of the comparators, including semaglutide in SURPASS 2, which reduces HbA1c by 1.8, and including also insulin degludec in SURPASS 3, which reduces HbA1c by 1.34. So you can see here that the reduction with especially the higher doses of tirzepatide exceed those seen with the comparators. This is another important piece of information, which is the proportion of patients that achieve an HbA1c level lower than 7%. And you can see here that this proportion is really close to 100% almost. So with the highest dose of tirzepatide, it is about 90, 92, 94%. So really a very important level of achievement of glucose control lower than 7%. But really, what is, I think, the most striking result from this program is, as we discuss the remission of diabetes today, the proportion of patients who achieve an HbA1c level lower than 5.7%, which is the upper normal range, the upper limit of the normal range for HbA1c. So really, this is something that we have to look at very carefully, because we can see how in these studies there's with the highest dose of tirzepatide 15 milligrams a proportion which is about 50% of patients that achieve normal HbA1c lower than 5.7%. So this is something that has not been seen before by any study previously. And also in terms of changes in body weight, you can see here how with the highest dose of tirzepatide, you can lose more than 10 kilos. So this is really something that has not been seen with any other intervention with drug therapy before in type 2 diabetes. So the proportion of patients achieving at least 15% of body weight with tirzepatide in these 4 studies, SURPASS 1, SURPASS 2, SURPASS 3, SURPASS 5, is really with the highest dose of tirzepatide between 27% and 43%, which is, I think, not, of course, equal to the efficacy of bariatric surgery, but very close to that. So this really, I think, highlights the possibility, as we recall, the need for losing at least 20% of body weight to be in a high probability of going into diabetes remission. This is something that really makes this intervention very promising, especially in regard to type 2 diabetes remission. So I think this is definitely better than what we can see even with the high doses of GLP-1 receptor agonists, including liraglutide, semaglutide, dulaglutide. So you can see how the proportion of patients that reduce HbA1c lower than 7% is definitely higher with tirzepatide as compared to the high doses of GLP-1 receptor agonist. Also, the proportion of patients with an HbA1c lower than 6.5%, and also the proportion of patients with an HbA1c lower than 5.7%. So clearly, this is something that was not even addressed or analyzed in these studies with high doses of GLP-1 receptor agonists. And also in terms of weight loss of at least 5%, or at least 10%, or at least 15%, you can see how tirzepatide is definitely more efficacious, bringing a higher proportion of patients to these ambitious weight loss targets, more than it happens with high doses of liraglutide, of semaglutide, or dulaglutide. So in conclusion, I think that tirzepatide is really the drug that today offers the largest extent of HbA1c reduction, ranging from 1.9% to 2.6%, the also highest proportion of patients who achieve the HbA1c target of less than 7%, between 80 and almost 100% of patients, the highest proportion of patients with normal HbA1c ranging from 23% to 62%. The largest extent of body weight reduction seen so far, which goes even up to less 13 kilos versus baseline, and an efficacy with different background therapies, including patients who are drug naive, who only are on metformin, are treated with oral agents, are on basal insulin, and also efficacy in patients with different diabetes durations, ranging from a mean of 5 years to a mean of more than 13 years. This occurs in the absence of excess risk of hypoglycemia and with a gastrointestinal tolerability profile that is similar to the one seen with GLP-1 receptor agonist class. And in terms of cardiovascular safety, we know the drug is safe. We also know that it will reduce multiple cardiovascular risk factors, including not only HbA1c and weight, but also blood pressure and lipids. We don't know whether the drug will reduce MACEs, but this is something that, as I said, is currently being investigated. So tirzepatide has potential for really providing, over the current therapies, greater glucose control, use in a variety of patients with type 2 diabetes, and also to induce the largest extent of weight loss. And as we have discussed also at the beginning of this talk, has all of the features to be important as a potential tool to induce type 2 diabetes remission, given the multiplicity of actions that this dual agonist is able to induce. I will stop here and thank you very much for your kind attention.